Welcome to everyone, dear colleagues. Congenital hip dislocation is one of the most important and challenging topics in pediatric orthopedics. And in my research, we are evaluating the conventional treatment of hip dislocation in order to find the most personalized treatment protocol. My name is Gyula Domos. I work as a pediatric orthopedic surgeon at Semmelweis University, and my vision is to ensure the highest quality treatment for pediatric patients and also to build one of the best pediatric orthopedic centers in Europe in 10-15 years. And in order to achieve the same, we have to introduce and follow the best available treatment methods in every field of pediatric orthopedics, and we also have to work out new treatment protocols. My current research fits well into this concept. In the first part, we are investigating the risk factors of failure in the treatment of congenital hip dislocation. Based on a systematic review and meta-analysis, we would like to define how we can reach the best results and avoid complications. In the second part, we are analyzing the results of our treatment protocol at Semmelweis University, which is different from the international protocol, but we seem to have better results and less complications with that. So my first study is about the risk factors of failure in hip dislocation treatment. We started this project in September and we are planning to finish it next May. According to the international protocol, after a failed conservative treatment with public harness, or in case of late diagnosis, a closed reduction of the dislocated femoral head is performed under general anesthesia. If the closed reduction fails, an open surgical reduction is needed, and if the open reduction also fails, additional surgery, femoral and/or pelvic osteotomy is performed. But complications are common with this treatment protocol, and in addition, the avascular necrosis, which is the most serious complication of the treatment, is common too. The overall rate of it is 10% in closed reduction and 20% in open reduction. What we don't know is the overall rate of failure and the risk factors of failure. But if we could identify the cases where the conservative treatment will probably fail, we could skip the conservative step in the treatment and we could perform immediately a closed reduction, and thereby we could avoid a lot of complications. If we could select the cases where the closed reduction will probably fail, we could skip the closed reduction step and perform an open reduction immediately. And based on this scheme, we could perform a complex surgery primarily if the open reduction will probably fail. So our clinical questions are, what are the risk factors and the overall rate of failure in the treatment of congenital hip dislocation? We are investigating 3 subgroups: children with conservative treatment, with closed reduction, and with open reduction. The intervention is the presence of risk factors, and the comparison is the absence of risk factors. And the outcomes are the rate of failure, rate of avascular necrosis, and secondary surgeries. Our hypothesis is that certain risk factors increase the rate of failure in the treatment of congenital hip dislocation. And what is the clinical implication? After identifying the risk factors in different treatment steps, we might be able to make more exact therapeutic decisions, and we can decrease the rate of unnecessary interventions and complications. I performed a systematic search on the 20th of October in 3 databases. My search key was about hip dislocation and reduction. I found more than 12,000 records, and after selection, we have found more than 100 eligible full text so far. So my second project is about the primary complex surgical treatment in congenital hip dislocation, and we started this project in October, and we are planning to finish it next July. At the Semmelweis University, we don't use the conventional international protocol in the hip dislocation treatment after a failed closed reduction or in case of late diagnosis because of the high rate of failure and avascular necrosis. During the treatment, we would like to avoid the forced reduction of the dislocated femoral head because we would like to avoid the damage of the blood supply of the femoral head, and which can cause avascular necrosis. So as we cannot select the cases where the conventional treatment will probably fail, we perform an open reduction, a femoral osteotomy, and a joint reconstruction in cases of late diagnosis and after a failed conservative treatment. Although we perform more surgeries than the other centers, practically we can avoid the redislocations and decrease the rate of avascular necrosis. So my project is about investigation of rate of complication and the late results of our project, our treatment protocol, sorry. We are collecting the data of our patients treated at Semmelweis University from 2008 and 2019 with a minimum 2 years of follow-up. Patients are children with congenital hip dislocation after a failed conservative treatment in case of late presentation and in case of syndromes, treated with open reduction and femoral osteotomy. We treated 116 children, 72 girls and 44 boys, and hip dislocation was unilateral in most of the cases in girls, and it was bilateral almost half of the cases in boys. So these are the two main topics that we are investigating during the following year, and we would like to finish next summer. And I wrote a quote from István Szepsi, who is a famous and internationally recognized winemaker. His words that the highest quality is our moral duty is a very important rule also in medicine, especially when we treat children. Thank you for your attention.
Thank you, Gyula, for your wonderful presentation. Is there any questions on the field?
Congratulations. I'd like to ask you if avascular necrosis does present, in what time frame would you expect it to occur? How long after the intervention?
After the treatment in 1 year, we can see the signs on the X-rays of avascular necrosis.
Thank you.
I have, again, as I said in many other talks, that I'm quite innocent or unknowledgeable. I mean, in your first PICO that you were talking about risk factors, and one of these is age. I mean, just to put their age, I mean, I just don't quite understand how age is going to be a risk factor. So the younger the better, or the older the better, or what?
The younger are the better. So we have to start the treatment as soon as we can. So the optimal age is below 1 month or below 6 weeks of age. The starting point. And
is there good kind of ways, patient ways for this? I mean, so they can reach you?
Yeah, there is a hip screening, a compulsory hip screening in Europe. In almost every country, so we have to check the babies under the age of 6 weeks.
Yeah, but if this happens, then how can you kind of evaluate this if everybody works at this very early time of age? Or still there are data from older ones?
So we have some babies with late presentations, unfortunately. So it's compulsory, but it's
not happening. Yeah.
It happens.
Okay. The other question is your second study. I mean, when you say that, I mean, all data are better than others. I mean, we believe you, but it could be difficult if you want to publish it unless you have a proper control group. So, what is the control in your study? Or do you have a control group, or you just compare that to the...
I think we don't need it, because we have to, so we would like to evaluate our results, and we would like to compare to the published data, but no controls, because we have to treat the patients somehow. And this is what we have been doing for 20 years, this protocol. And we have to compare to the published data.
I understand that very well. I mean, that you try to do your best. And then you are the experts, actually, so you know what to do on a clinical side. But on the other side, if you want to, in quotes, sell it, I mean, so make it public in a way that others will follow your method, I mean, you need some kind of comparison, not only the historical ones, because then they may not believe you, you see, when you publish this.
then we'll discuss it.
The other thing, I mean, this would be, I mean, that's, I don't know if this is realistic, but could this be done in a kind of international level? I mean, a study, I mean, running a study on this at the international level, I mean, in multi-center, and maybe not only in Hungary, but in kind of multiple similar kind of
maybe, but the international
centers.
yeah, maybe, but the international protocol is different from our protocol, so it's not.
I understand,
not
but you want to break through.
Okay, but nobody believes us yet.
But that's why you need a control group. You see,
Yeah, okay.
I mean, even if you don't like it, anyway. I mean, I know that this is a kind of serious ethical kind of problem. I mean, all these kind of studies, you still have to do that somehow.
Okay, thank you very much.